everybody. I want to thank you all for taking your seats now. I'm so excited that this morning session has generated so much enthusiasm. But we'd like to start the next session. You know, we've planned today so that there'll be a lot of time around lunch where you can look at our exhibits and talk with each other, and we hope you all take advantage of that. But meanwhile, thank you for taking your seats for our next general session. The session is entitled Beyond Medications, Advances in Epilepsy Treatment, and is generously sponsored by Spectrum Health. We're pleased to have as our speaker today Dr. David Burdette, an adult he has a following here, we know, an adult epileptologist with Spectrum Health's Comprehensive Epilepsy Program. I know this is an important topic, so let's get started. Dr. Burdette?
Always a pleasure to come to this side of the state and speak for the Epilepsy Foundation of Michigan. And I've got an interesting topic today. Of course, I find every topic as it relates to epilepsy interesting, as I'm sure do you. But we're going to talk about some advances in the area of epilepsy. Before we jump right into to these topics, these advanced topics, if you will, and some fairly standard topics, actually. So I've got some standard topics and some advanced topics. But it's going to revolve around the non-medical treatment of epilepsy. And you heard a very comprehensive presentation from Dr. Stacy about the underpinnings of epilepsy. So I'm going to piggyback on that and give you a framework from which we're going to talk about these various treatment modalities. If you want to use a football analogy, we're going to start with the Vince Lombardi. This is a football, and then we're going to work our way to the veer offense or the spread offense, something like this. We're going to start simple and go big. So, in starting simple, and let me see if I have a pointer up here. I believe I do have a pointer. So epilepsy, an epileptic seizure, in its heart of hearts, is going to be the result of excessively synchronous neuronal firing. And this ultimately goes back to neuronal networks. So this is a bit of an oversimplification here. But we have in our brain neurons that are excitatory, and every time they fire, they make every neuron that they're impinging upon or that they're synapsing with more likely to fire. And then there are other neurons that are inhibitory. Every time they fire, they make every neuron that they're synapsing with less likely to fire. And as you can imagine, we need that balance. We got to have that balance between excitation and inhibition. So throughout our brain, we will have these neuronal circuits, and you may have an excitatory neuron, and every time it fires, it makes this neuron more likely to fire. Every time this fires, it makes this one more likely to fire, dot, 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 coming back to the first one. And lest this start to fire out of control of its own accord, we want our neurons to fire when they're supposed to fire so that you can move your arm when you want to move your arm. You can see things, sense things when you're supposed to be sensing them. You can think your lofty thoughts. We don't want our brain to be firing of its own accord. So we have a brake that's built into the system, and every time this excitatory neuron fires, it makes this inhibitory interneuron more likely to fire, but when it fires, it is inhibitory. And so it's the brakes built into the system. So we're maintaining this balance between excitation and inhibition. And if for some reason you've got an area of the brain, maybe some cortical dysplasia, something whereby you don't have enough of these inhibitory interneurons, then you can have a situation where this neuron fires. This one not only wants to fire, but it does fire. This one not only wants to fire, but it does fire, does fire, does fire, does fire. And the first thing you know, this network is firing out of control, and that person is segued into a seizure. And that seizure isn't firing in a vacuum. That network is connected to thousands of neighboring neurons. So they try to entrain the firing of their neighbors, and then they try to get their neighbors to fire, and that is how a focal or partial seizure spreads. So we've got this brain here, and we've got this little pesky area that is firing out of control. Person may not even be aware of it. It may be a subclinical seizure, and it may continue to spread. At some point, it's going to give symptoms, and a person might have an aura, a simple partial seizure, and it may continue to spread. At some point, it's probably going to spread to the memory-forming parts of the brain, and that person is going to blank out. They may have unresponsive staring, automatic hand movements, things like this. But the brain, in a sense, knows, if you will, colloquially speaking, that it's not supposed to be having a seizure. It has these intrinsic mechanisms for terminating a seizure. A single seizure is going to be a self-terminating event. Now, seizures may occur back to back to back, which is a problem, but a seizure is typically a single event. It has a start and an end. Why does it end? Well, the brain has these intrinsic ways of fighting the seizure. So through a combination of neuronal exhaustion, of increased inhibition, and various other conformational changes in ion channels and whatnot, it becomes harder and harder for that part of the brain to seize. And so you will end up having that seizure terminate. And that seizure may end with a very brief seizure, or it may continue to spread, and if it spreads, it may even spread to an entire hemisphere or go to the entire brain where you have a secondarily generalized tonic-clonic seizure. So that is, as you know, how, at least with partial epilepsy, focal epilepsy, which is the most common type of epilepsy in adulthood and about half of seizures in childhood, this is how seizures progress. So what I'm going to be referring to is this little pesky seizure onset zone, this network of neurons that wants to fire out of control. And it may be a really focal network in a very small part of the brain. It may be a broad network. And with focal onset seizures, if this gets going, it may spread a little bit. A person may have a mild seizure, may have a more severe seizure, may have a full-blown generalized tonic-clonic seizure. We're going to have the central nervous system's intrinsic mechanisms of limiting that seizure, opposing that spread. And our first line of treatment, as you know, is anti-epilepsy drugs. So our risk of having a seizure at any given point in time can arguably be determined by how hard is this network pushing to move us this way on the continuum, and how aggressively is the central nervous system opposing that spread, and how aggressively are those anti-epileptic drugs opposing that spread. So anti-epileptic drugs, how well do they work? With the first, if you have new onset of seizures and you're started on a reasonable dose of a reasonable medication, you have a little less than a 50-50 chance of successfully becoming seizure-free. So if we take that 53% of people who are having ongoing seizures despite having been started on a reasonable dose of a reasonable medication, then we could say, okay, that first drug, it was a good idea, but it didn't work. Let's go with a second anti-seizure medication by itself, and we'll pick up another 13% of people. So with the first two drugs, 60% of people seizure-free, give or take, 40% of people still having seizures. Okay, well, in that 40%, let's keep plugging away. So let's switch them to a third drug by itself. Unfortunately, we pick up 1 to 2% of people, so we're starting to reach a point of diminishing returns. Let's go with a combination of medications, pick up another 3 to 4%, and it becomes evident that over time, if we want to get to 100% of people seizure-free, with medication treatment alone, that curve starts to level off at about 2/3 of people. So at about 66, 67% of people, their seizures can be controlled with reasonable trials of reasonable anti-epileptic medications, leaving about 1/3 of folks who continue to have seizures despite our best efforts at controlling their medications or controlling their seizures with medication. So what do we have to offer to the medically refractory patient? Well, I'm going to talk about 2 broad categories of treatment. One has to do with resecting or ablating a part of the brain. That if we can identify that network or the key components of that network that are causing the seizure, and we can either have a neurosurgeon, an epilepsy neurosurgeon, remove a key part of that, or to ablate that, then that person has a certain percentage chance of being seizure-free. And we will also talk about what I will term neuromodulatory procedures. So the brain remains intact, but we are going to stimulate the brain. And I believe Dr. Stacy hit on that, so we'll talk a little bit more about that. About affecting the firing rate of that or those networks of neurons. So let's go back to our model here. So we've got our pesky seizure onset zone, trying to push us this way on the seizure continuum, central nervous system pushing back, and anti-epileptic drugs trying to control this area. We now have determined that we are medically refractory. Despite our best efforts, we're continuing to have seizures. So our goal now is going to be, we're going to talk about ablative or resective treatment. We are going to try to rid ourselves of this seizure onset zone, this network of neurons that is trying to produce seizures. And there are a number of resective surgeries that have been utilized over the years. The most commonly used have been a standard temporal lobectomy or amygdalo-hippocampectomy. And there are a number of other procedures that I'm going to mention along the way. This is data from the early 1990s. This is survey data from tertiary care epilepsy centers at the time and their best estimate, excuse me, of where, of how often their patients were seizure-free. And you can see that the highest seizure-free rates are kind of approaching 70%. And in our first 2 columns here, we're talking about anterior temporal lobectomy and amygdalo-hippocampectomy. So what the heck does that mean? Well, here we have a brain, and we have the front of the brain, the back of the brain, and that temporal lobe coming around the side. The temporal lobe is the most common site of origin for partial onset seizures or focal seizures. So the temporal lobe in and of itself, when it is functioning normally, is chock full of those reverberating circuits, those networks, those excitatory networks. And so if you ding that temporal lobe, or if you have an issue in the temporal lobe whereby there's a little bit of an imbalance between the excitatory part of the circuit and the inhibitory part of the circuit, the temporal lobe tends to be very epileptogenic. So it's no great surprise that the temporal lobe is generally believed to be the most common site of origin for partial onset seizures. And there was a study done that was published in the early 2000s that looked at the role of epilepsy surgery in temporal lobe epilepsy relative to the role example of ongoing trials of medication if you were medically refractory. This study was done in Canada because in the late 90s in Canada, the Canadian medical system was set up in such a way that if you had been tried on multiple anti-epileptic medications, were continuing to have seizures, were determined to be a good candidate for epilepsy surgery, you had to wait a year for surgery. So they took a group of patients and they randomized them. Half of them went the standard route where they waited the year for surgery and then got their surgery, but during that year they had changes made to their anti-seizure medications in order to try to get them seizure-free, because ideally you'd like to be seizure-free without surgery. And the other half of those patients, they got to jump to the head of the line and go directly to surgery. And then in this randomized fashion, for a year, it was assessed who had the better outcomes. The surgery that was done in these individuals was a standard anterior temporal lobectomy. Here's our temporal lobe, and the anterior, the front portion of that temporal lobe was removed. It was a little more aggressive resection on the side, the non-speech dominant side, because didn't want to affect the person's speech. But if this was, I wouldn't say it still is the most commonly performed epilepsy surgery, but for many years was the most commonly performed epilepsy surgery. I'll also point out amygdalohippocampectomy, one of my favorite long medical words, right next to the great radicular artery of Adamkowitz. And an amygdalohippocampectomy is going to take out, ectomy, the amygdala and the hippocampus. Your amygdala and hippocampus are in this region, in kind of the underside of your temporal lobe. So you're going to take out, do a more focused resection, and generally the outcomes from this are similar to that of taking out the entire temporal lobe. It is still debated over the long haul if the outcomes are as good, the seizure-free outcomes, but nevertheless, these two are two of the most common epilepsy surgeries that are performed. So using this standard anterior temporal lobectomy surgery, we have a comparison of patients who had their year of medical therapy, trying new medications, trying to get after those seizures using the medical route versus patients who had surgery. And you had an 8% chance of achieving freedom from seizures with just trials of medication, whereas 64% of the patients were free of all seizures except for auras. If you include auras, or simple partial seizures, then that number fell to about only 42% of people were free of everything, and 3% of patients with medical therapy. So the upshot of this was that clearly, if you have medically refractory epilepsy, you've been tried on reasonable trials of multiple anti-epileptic medications, and we can determine that your seizures are arising from your temporal lobe, that the chances of you being seizure-free are greater if you have epilepsy surgery than if you continue trying repeated trials of medication. That having been said, it's not a 0% chance that you will be seizure-free if we continue with medication. So that accounts for these first two lines here. The next line is this yellow line that's hitting at about a 45% chance of people being seizure-free except for auras. And these were people who had neocortical resections. So once you get outside of this underside of the temporal lobe where you have all these well-defined, tight networks that may cause seizures, but it's not that difficult for a neurosurgeon to get in there and take out those networks. Once you get to other parts of the brain, these networks become more complex. And because they're more complex, they're harder to identify, and even when you take out a portion of that network, the seizures may continue. So the outcomes are not quite as good. Our outcome then jumps up a little closer to 70% again with what you would call a lesionectomy. So a lesionectomy, a lesion, some area of badness in the brain. And so outside of the temporal lobe, so extratemporal, if we have a lesion, an area of cortical dysplasia, an abnormality that's been there the person's entire life, but very focal, a prior abscess, anything that could cause scar tissue or gliosis in the brain. And you can see it on the MRI scan, and we record from the brain, and we prove that the seizures are coming from that area, then we've got a pretty good idea that that network that is producing the seizures is tied to that area. And lo and behold, if you then take out that area, the chances of being seizure-free jump back up to approaching that 60 to 70%. We also have good outcomes with hemispherectomy. This is not something that you would want to necessarily do in an adult, but in young children, when we're young, our brains have this inherent plasticity. Parts of the brain can pick up the slack for other parts of the brain if there's damage or if that part of the brain is removed. And if someone has seizures confined to one half of the brain, and that those seizures are so frequent that that young child is not able to function because one hemisphere is just dragging them down, then they are a candidate for hemispherectomy, where you remove the network that involves that hemisphere. And again, that child has a high chance of being seizure-free, and the earlier in life it's done, the greater the chance that the other hemisphere will pick up the slack for that. So those are the primary resective epilepsy surgeries that are out there and that are regularly being performed at level 4 epilepsy centers. And there are a number of level 4 epilepsy centers present throughout the state. The reason, and there are multiple reasons that we're talking 60 to 70% chance of being seizure-free. You could ask, why isn't it 100% chance? We've identified from whence the seizures are arising. We take out that area, we should be able to make that person seizure-free. And there are many reasons. I'll speculate on two of them right now. One reason is that if you have, for instance, two areas of the brain that are prone to having seizures, and one area of the brain just intrinsically maybe has a seizure once a week, and another area of the brain that is not too far removed from it will have a seizure on average, say, once a month. Well, the weekly seizure that starts in that part of the brain will invariably spread to involve the second seizure onset zone or the second network, and will shut it down. And so it ends up that one area of the brain will be driving the seizure frequency, and you can come into the monitoring unit, we can record seizures till we're blue in the face and you're blue in the face, and we only see that one seizure onset zone. But when that is taken out, it lets that other seizure onset zone rear its ugly head. So there's going to be a small percentage of people where that occurs, and then in a number of individuals, these networks are much more complex than we would like to think, and involve far-reaching areas of the cortex, and just taking out one area will result in improvement in seizure frequency, but not necessarily make that individual seizure-free. So that is the story with resective surgeries, and that story has been written in previous years. What is changing now is that with improved technology, we are able to take people who are in that lesionectomy group, where we didn't see any abnormality on their MRI scan, so we don't have a target, if you will. We do our studies, that person has the resection, and they're running 40-45% chance of being seizure-free. with improved MRI technology, newer modalities like magnetoencephalography, but particularly with the imaging modalities, with better MRI scanning, we're able to identify lesions that we previously couldn't see, and to convert some of these individuals from a non-lesional group into a lesional group where we see that subtle lesion, and now they've gone to a better outcome group. So let's shift gears. We've been talking about having a neurosurgeon go in, crack open the skull, and take out an offending area or occasionally areas of the brain. Is there a less invasive way of doing that? And in fact, there are two ways that are done and have been done over the past couple of years where you can remove the offending area of the brain with in a less invasive. One is non-invasive, and one is a less invasive fashion. You're still left with needing to meet two criteria. First criterion, we need to prove that your seizures are coming from one part of the brain. And the second criterion is, if that part of the brain is removed or ablated, you will be the same person walking out the door that walked in the door. That is just the overriding goal when it comes to epilepsy surgery. So let's talk about laser ablation. Laser ablation is less disruptive for the patient's life, for the brain, for the body, than is standard resective surgery. And with laser ablation, you will have an area of the brain that is identified, and it may be the temporal lobe, and you've identified it with non-invasive testing, or it may be deep structures in the brain that have a lesion that all indications are that the seizures are arising from that lesion. And stereotactically, using MRI guidance, the neurosurgeon will introduce a laser-tipped catheter through a burr hole in the brain and will target the offending area of the brain. Most of the data, the outcomes data from this, has to do with the temporal lobe, but this has been done with a number of other structures. In this case, this is being done in the inferior frontal region. So there's a burr hole placed in the brain. This catheter is stereotactically placed, and then that laser tip is heated. And we get a heat map where at the core of it, it's almost to the boiling point of water. It's about 77 degrees centigrade, and then that falls off rapidly. And what that does is it ablates that area of the brain. And in so doing, if that area corresponds to the entirety of, or the primary regions of that epileptogenic focus, that network, then that person has a good chance of being seizure-free. And because it is less invasive, patients are typically hospitalized for a shorter period of time. So a patient comes in, has the ablation performed, home the next day, and oftentimes patients are able to resume their normal activities within 2 to 3 weeks. So a little quicker to bounce back from that. The outcomes from this are best identified for temporal lobe epilepsy, where that laser-tipped catheter is implanted from the back, and it aims forward, hits that amygdala and hippocampal area, and ablates that area. And early data indicates that the outcomes from ablating that area are similar, or in the ballpark of the outcomes that you get from a standard resection, taking out the amygdala and hippocampus. What we don't have are long-term data to say that it's going to hold as long as resective surgery would. But that is in the works. But it's nice to have a procedure that is a little less invasive than having someone crack open the cranium and go in and physically take out that part of the brain. You may also have heard of gamma knife radiosurgery. Gamma knife radiosurgery is an interesting technique, and this involves having a beam of radiation, let's say from here, and it will shoot through the brain. And it is very focused. So this focused beam of radiation, anything in its path is not being hit with that much radiation to cause pathology, badness in the brain. And we've got another beam of radiation, and it shoots through the brain. Again, anything in its path is not being hit with enough radiation to cause damage. And another, and another, and another, but you will notice that the radiosurgeon will have calculated that all of these are going to cross paths at one target. And suddenly at that target, the cumulative radiation isn't from a single line, it is the cumulative radiation of all of those beams of radiation. So what ends up happening is you have a benign beam that comes in, a benign, but where they all intersect, it irradiates the heck out of that area. So if you have an area of the brain that is deep, hard to get to, and is causing seizures, then this is a means of, in essence, removing that area of the brain using a fairly high dose of radiation, but all of the surrounding areas will be minimally affected. And what is interesting with this, here we have most of our data, once again, because the most common site of origin for seizures is the temporal lobe, specifically the mesial temporal lobe, the underside of the temporal lobe. And true to form, most of the data for this is from mesial temporal lobe epilepsy. Most of it is from France, from Régis. And Régis' work, this is a typical series of MRI scans. This individual had right mesial temporal lobe epilepsy. And this is about 9 months after gamma knife. And we see that it doesn't look that different from the other side. But this right side has been irradiated. And so those neurons are going to die in that seizure onset zone. It's just going to take a little while. There's going to be a lag time. But by 17 months, we have fairly significant cell death in that area that was causing the seizures. By 27 months, the cell death is largely complete. We have remaining edema or swelling. And then finally, the edema is resolving by 36 months, and we're left with an area of scar tissue there where there used to be a seizure onset zone. What was seen in the French experience was when gamma knife was performed, it was not uncommon to see an uptick in seizures initially, and then the seizures would taper off, and by about 10.5 months, you would see, if you were going to be seizure-free, you would be seizure-free by that period of time. The gamma knife has gone a little bit out of vogue for temporal lobe, or has gone out of vogue for temporal lobe epilepsy because the ability to sustain that freedom from seizures wasn't as great as with standard temporal lobe surgery. And where this is most commonly used now is in the setting of, say, hypothalamic hamartomas or abnormal collection of blood vessels that are deep in the brain and hard to get to. So we've talked about the most commonly available resective and ablative surgeries, and these are designed to get at that seizure onset zone, that network of neurons that is producing these ongoing seizures. What else can we do? Well, we can do neuromodulation. We can augment the brain's ability to fight off a seizure. So let's talk about neuromodulation. Well, first, let's kind of compare with resective or ablative surgery. We needed to have two criteria sufficed. One was we needed to have ideally a single seizure onset zone. We needed to identify one part of the brain that was causing the seizures, and we needed to prove that that was not eloquent cortex. It was expendable cortex. You would be the same person walking out the door that walked in the door. With neuromodulation, we do not need to meet those two criteria. We can affect neuromodulation in more than one part of the brain, and we're going to talk about that. So if you have seizures that are arising, maybe even diffusely, you have generalized epilepsy. 1 second the brain is fine, next second both hemispheres are going at the same time with the seizure. Probably not a candidate at the present time for epilepsy surgery, but potentially a candidate for a neuromodulatory intervention. If you have seizures arising from two areas of the brain, the more areas of the brain that have surgery, the greater the chance you're going to have an issue after surgery. So we may not want to take out both of those areas, but maybe we could implant something in those areas, and through this neuromodulatory process, reduce your chance of having a seizure. Or you have seizures arising from an area of the brain that you need in order to speak, think your lofty thoughts, move the opposite side of your body. We can implant a strip or strips of electrodes or depth electrodes and try to modulate the activity arising from those parts of the brain. So neuromodulation, what the heck is neuromodulation? It's a really fancy term, you know, like amygdalohippocampectomy. It just sounds good. It would sound better if I had an English accent, but it still sounds pretty good just saying it. So neuromodulation, the original concept was based upon this notion of a far-reaching effect from chemicals within the brain. So ordinarily, we've got our nerve cell, and this nerve cell interacts with this nerve cell at what we call a synapse. So one nerve cell affecting one other nerve cell. But with neuromodulation, it's a process whereby a single nerve cell will have a chemical effect on a wide variety of nerve cells, have a broader effect that isn't this one-to-one synaptic interaction. So that was kind of the original idea of neuromodulation. And how this concept has evolved is when you take a step back, you know, we can talk about the chemicals that are involved in nerve-to-nerve communication. But in the end, the brain works, for lack of a better term, by electricity. The electrical currents are driven by ion channels opening when they're supposed to and closing when they're supposed to, maintaining the balance that they're supposed to have. But in the end, our brains are working by electrical currents that are firing when they're supposed to fire and not firing when they're not supposed to fire. So this idea of neuromodulation has more recently been applied to electrical phenomena, where we apply electrical currents to neural structures and we have effects on broad networks of neurons. So most of what I'm going to discuss, except at the very end, I'm going to mention a few cutting-edge topics, but what is available now has to do with stimulation of the brain. And stimulation of the brain is going to be either termed open-loop stimulation, where you've got a stimulator and it stimulates at regular intervals, just boom, 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 does it around the clock, regardless of what you're doing, regardless of what is going on with the brain. And we differentiate between that open-loop stimulator and a closed-loop stimulator, where the stimulator only fires in response to some phenomenon. And what that phenomenon is will depend upon the type of stimulator it is. So it detects some phenomenon, and then it stimulates the brain. So we will have open loop, around the clock stimulation, and we will have responsive stimulation. Open loop stimulation has been done on a number of targets within the brain, ranging from the basal ganglia, the caudate nucleus, subthalamic nucleus, and these are all for epilepsy. Deep brain stimulation for Parkinson's disease is a form of open loop stimulation as well, and very prevalent, but these are targets that have been used for epilepsy, with probably the most common target within the brain being the thalamus. But I'm going to start with the cerebellum. The cerebellum, whenever you see a picture of the brain, you see the cortex, then you see this little part of the brain sitting underneath. And this is our little motor computer. And if my cerebellum were lopped out, I would not be able to maintain my balance. I would not be able to hold my hand out here. It would just be out of control. So it's our little motor computer back here. And there is a lot of inhibitory outflow from that little motor computer, and someone got the bright idea in the 1970s, in 1960s and 1970s that, well, we've learned by that time that epilepsy, there's too much excitation, not enough inhibition. Let's stimulate that cerebellum, and maybe we can decrease seizures. And lo and behold, it actually wasn't that bad. I had a patient when I was in the Air Force in the early 90s. They had paid for medical school, and so I was doing my Air Force payback time as a general neurologist, saw a surprising number of epilepsy patients, but one of my patients had bitemporal epilepsy, seizures arising from both temporal lobes, and at that time, there was nothing to be done for that. You can't take out both temporal lobes, otherwise you'll be left with an inability to form new memories, in essence, from that point on. And we didn't have these neuromodulatory devices that we have now, but her husband did say that in the 1970s at the Mayo Clinic, she had been evaluated, shown to have seizures arising from both temporal lobes, and it had a cerebellar stimulator implanted, and had gone seizure-free for 2 years. And this gal didn't go 2 days without a seizure when I knew her. She went seizure-free for 2 years, but alas, the technology at the time was limiting. It was unknown how much actual current was being stimulated from stimulus to stimulus. There were frequent equipment failures, short battery life, and the leads were very fragile. She actually suffered a fractured lead that was replaced once, but ultimately her seizures inexorably returned. So this did not work out for her, but the concept of cerebellar stimulation is still FDA approved. It's just that now we do not have an available cerebellar stimulator. So if someone has their heart set on cerebellar stimulation, they will have to develop a cerebellar stimulator because there is no FDA-approved device for this. The next device to be approved was the vagus nerve stimulator in 1997 for the treatment of medically refractory partial epilepsy. And then the newest and greatest form of that was approved last year, which was the Aspire SR generator. So this is the original model, Model 100, and this is an open loop stimulator where your epileptologist will program how often it fires and with how much kick it fires. And it is implanted over the left chest wall. It is attached to the left vagus nerve. And this fires on a regular basis and has generally over time a neuromodulatory effect that as this device is in, there is a gradual decrease in seizure frequency. And additionally, it has the potential to abort a seizure. There was with the original and with the latest of the standard, this demi-pulse model, there's a magnet-activated setting. So if someone feels that they're about to have a seizure, they can swipe the magnet and have it fire right then and there, perhaps with a little more kick, and potentially abort a seizure. With any of these devices, the sooner the device fires, the greater the chance that you could abort an event. And that led to the Model 106, and it is known that the most common electrocardiographic, the most common heart-associated accompaniment to a seizure is tachycardia. So typically when someone goes into a seizure, their heart rate jumps up quickly. Now, when we exercise, unless you're out of shape like I am, your heart rate will gradually increase when you exercise. But if someone has ictal tachycardia, that seizure starts and that heart rate jumps right up. So with this Aspire model, what it is designed to do is we've got our background heart rate that'll have its ups and downs, and your epileptologist will program it to say, okay, if the heart rate jumps up 60%, 70% over the course of 5 heartbeats or 3 heartbeats, then we're going to have this vagus nerve stimulator fire. And so this is another way that you can kind of move up that firing and try to intervene with this neuromodulatory effect as quickly as possible after onset of a seizure. So how else might we modulate the brain? Other open loop stimulators have been done in the thalamus. And the thalamus has probably been the most common target for open loop stimulation for brain implanted devices. The 2 most common nuclei, the thalamus is this deep structure in the brain that has reciprocal connections with all areas, almost all areas of the cerebral cortex. And the anterior nucleus of the thalamus has copious connections with the hippocampus, which is part of the temporal lobe. We've talked about the hippocampus, amygdalohippocampectomies. So it would make sense that if you could stimulate that anterior nucleus of the thalamus, you could potentially suppress seizures arising from the hippocampus. There are also a number of connections between the anterior nucleus of the thalamus and the frontal lobes, which is the second most common site of origin for seizures. There's been a little bit of work with the dorsomedial nucleus of the thalamus that is has a lot of reciprocal connections with the amygdala, and remember amygdalohippocampectomy, but there isn't any ongoing work to my knowledge at the present time. There was, however, a large multi-center trial, the Sante Trial. Sante, stimulation of the anterior nucleus of the thalamus for epilepsy. This was open loop stimulation. If you look at the data and remove a few of the outliers, the data actually looks pretty good. Like this is a very promising device, but it is not yet FDA approved, in large part driven by, there was one patient in the trial, the so-called outlier, and when they would implant this device, and this would be implantation of an electrode in both anterior or front nuclei of the thalamus, and then they would be hooked up to a Medtronic stimulator that was open loop, and that stimulator would fire at 5 volts. So this person had it implanted, and they turned on the stimulator, and his seizures just went crazy. He had hundreds of seizures. So, needless to say, they turned it off. But he had to be included in their data set that they presented to the FDA. When they turned it off, seizures went away. So clearly, stimulation of the anterior nucleus of the thalamus was not particularly good for him at that setting. Now later on, once he was out of the trial, they turned on the stimulator, but at 4 volts, and I have been told that he actually did better. So it just turned out that it was a dosing issue. He was put on too high a dose, but that was what the protocol said, and that sort of blew up the statistics for the trial, and it was back to the drawing board. Excuse me, but there is an ongoing trial looking at this, and it wouldn't surprise me if this is ultimately FDA approved. One of the most recent breakthroughs, if you will, has been in the setting of direct cortical stimulation. There were some, so that would be stimulation on the surface of the brain. And there is one device that is FDA approved for stimulation of the surface of the brain. And this is not an open loop stimulation. This is not around-the-clock stimulation. This is a responsive stimulator, a responsive neurostimulator, or RNS. And so in this instance, we may have an individual who has temporal lobe seizures, and maybe seizures arising from elsewhere in the brain. So either seizures arising from 2 parts of the brain that are not amenable to resection, or from one part of the brain, but that part of the brain is critical for that person's normal daily functioning. So either depth electrodes, strips of electrodes, some combination thereof are implanted over the key part or parts of that epileptogenic network. The outflow from that is plugged into a microcomputer that's about this big, wafer thin, embedded in the person's skull, so it's flush with the skull surface. And this microcomputer continuously monitors the EEG that arises from that epileptogenic network. And so this computer, you can interface with the computer. So if you have one of these implanted, then your epileptologist can hold a wand up there and can interface with it and can tweak how is that computer able to recognize a seizure. And it turns out if you record a seizure directly from the brain right over the key portions of that seizure onset zone, the key portions of that network, every seizure looks the same. I say that a seizure, once it spreads, every seizure is kind of like a snowflake. A seizure may sort of propagate this way and whatnot, and every seizure is going to be different, but when it starts at that seizure onset zone, every seizure is going to look almost exactly the same. So it's possible to teach a computer to recognize when that seizure happens. So here we have an individual who has depth electrodes in their left hippocampus, that underlying part of the brain, on the left and on the right. So had bitemporal onset. You can't take out both hippocampi. You'll never have another memory. So we don't want that to happen. As is often the case with hippocampal seizures, here is a seizure, excessively synchronous neuronal activity. That network of neurons is boom, 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 just getting going, and you can see the electrical field that accompanies that. And very commonly, as it's gearing up, you'll see this preictal spiking. So we've got preictal spiking, then boom, the seizure takes off. And in this individual, every seizure looked like this. So the first step is this is implanted, and we've got a detector A1, we've got a detector B1. Our A1 detector is all over this onset. So, excuse me, your epileptologist dials in that detection, gets that detection as quickly as possible. Once that detection is dialed in, then this is a different patient where, once again, we see that rapid fire activity. This is about 90 seconds of brainwave here. See this rapid fire activity from the seizure, and then the stimulator is turned on, and we see the seizure detected, and when the stimulator is turned on, that computer reverses the current, shocks the brain. You can't feel it because the brain doesn't have pain receptors, and it should modulate how the seizure spreads. It should decrease the spread of the seizure. It should decrease the duration of the seizure, and if you're right on it, it may abort the seizure. So the key with this, just like with the neuromodulatory vagus nerve stimulator, sooner is better. In this instance, we see everything is compressed. This is 3 minutes of brain waves. We see the seizure is taking off, where it's just going like a banshee here, and the detection is too late. So bang, 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 bang. There are 5 shocks to the brain, nothing happens. In this instance, it starts to take off, shocks the brain, and it's able to abort a seizure. So sooner is better, regardless of what you're dealing with. So those are the available technologies that we have for resection, ablation, and now for neuromodulation. Real quickly, in the final minutes here, I'm going to run through a couple of topics that are investigational. These are not readily available, but one area, and these are in alphabetical order, we're going to go from acoustic pulses for electrical status epilepticus in sleep, all the way to transcranial direct current stimulation. So there is a phenomenon in childhood, typically appears between the ages of 2 months and 12 years. Maximal expression is around 4 to 5 years. And these are kids who, when they go to sleep, their brain, in essence, goes into status epilepticus, just continuous spike wave discharges for more than 85% of the record. And there are a number of different treatments for this. It's associated with some neurocognitive decline. And a new area has to do with giving acoustic pulses through hearing earphones. And these continuous spike wave discharges happen in slow wave sleep, and the investigators identified that a slow wave, during the up phase it was excitatory, and if they gave this auditory pulse of sound on the up phase, it would bring out the spike waves. If they did it on the down phase, it would suppress the spike waves. So this will be a form of responsive therapy where pulses are given on the downside of that. And there's some early indications that this may be beneficial, but it's really in its infancy. There's another form of stimulation, neuromodulatory, that would be along the lines, perhaps, of vagus nerve stimulation, but your sensation from your face is it's your trigeminal nerve that supplies sensation to the face. And so with this device, there is, in the first division of the trigeminal nerve, a stimulator that is placed, and this stimulates around the clock. A person puts it on at night for 6 to 12 hours, and there's some early data to suggest that there's a reduction in seizure frequency from this. For multiple types of seizures, we don't know how long it's sustained. It is approved in Canada and the US. It is not yet, in Canada and Europe, but it is not yet approved in the US, and we will see what comes of that. You can do focused ultrasound. If you do a really intense ultrasound that is introduced through the skull, you can actually cause a seizure. But if it's intense enough, you can actually cause ablation of some deep structures in the brain. And there's a group at the University of Virginia who is looking at this for hypothalamic hamartomas. There's another group out west in UCLA who are looking at lower intensity focused ultrasound to suppress brain activity and suppress spread of seizures. If you remember, we have our neuronal circuit here that can be a source of badness. One issue is if we don't have enough inhibitory interneurons. So there's been animal work done looking at progenitor cells, stem cells, that are injected into the seizure-causing part or parts of the brain, and then these mature into GABAergic cells, which will increase the number of GABAergic interneurons and therefore ideally decrease your chance of seizures. We don't have human data yet, but there are human trials that are getting started. There's focal brain cooling. If you cool the brain, it decreases the electrical activity and stabilizes those nerve membranes. If you overheat the brain's a little more likely to have a seizure. And there's some devices that have been designed and used in animals, have not yet been used in humans, but it is known that before you have a seizure, the brain gets a little more blood flow, starts to heat up, and if you could cool it, you might be able to abort a seizure. Transcranial magnetic stimulation is a device whereby you put this device to your head and it creates a powerful magnetic field that in your brain creates a number of small electrical currents. This can be a double-edged sword. You can actually cause a seizure with this, but if you do it in a repetitive fashion, it can have an inhibitory effect on large parts of the brain and reduce your chance of having a seizure. And there are ongoing trials at Beth Israel in Boston looking at this. And then transcranial direct current stimulation. Direct current is the current of the type that would come out of a battery. And direct current coming out of the negative or associated with the negative end of the battery could actually produce seizures, but that coming out of the positive end of the battery can suppress cortical excitability. There have been no systemic studies of this, but some early studies in humans have suggested that this non-invasive process might be helpful for neuromodulation. But in the end, when it comes to non-medical treatments, we have our resective and ablative treatments, we have our neuromodulatory treatments. And with our current range of therapies, if you have seizures arising from one part of the brain, that part of the brain is expendable, then your greatest chance of being seizure-free from the get-go is likely going to be a resective or ablative procedure. If, however, you have seizures arising from more than one part of the brain, or seizures arising from eloquent cortex, that it would be risky to remove it, then your best option is neuromodulation. And depending on the parts of the brain involved, you may be a candidate for responsive neurostimulation. You may be a candidate for vagus nerve stimulation. And with vagus nerve stimulation, although the approval is for partial onset seizures, there is good data that it can be quite helpful for generalized seizures as well. Other ablative techniques are available and are helpful in specific circumstances. Where we expect to see further improvement will be a refining of the process to identify from whence the seizures are arising, moving people from this vague idea of extratemporal non-lesional to extratemporal lesional. Once we have a lesion and X marks the spot, if you will, then we've got a better target for either epilepsy surgery or responsive stimulation. And we will, over time, be better able with technologies like magnetoencephalography to identify epileptogenic networks. We're going to learn more about our neuromodulatory effects. There are thousands of different settings for vagus nerve stimulation or responsive neurostimulation, and we have good general ideas about some of those settings, but we still have a ways to go to better define what all of those settings do. In the end, though, it comes down to that network of neurons. And if we can, whether that network be focal or broad, if we can interrupt that network, we have the greatest chance of being able to significantly reduce your seizures and ideally render you seizure-free. I did, during the course of the talk, mention a number of experimental options, and if you're interested in participating in trials, 2 websites that you can go to are epilepsy.com at the Epilepsy Foundation website, where they have clinical trials mentioned, and then clinicaltrials.gov. And I thank you very much for your attention.